So I'm going to go through Screening 101 here and try and give you a little bit of background about screening in general and how the cancer screening programs have been developed and brought out so that you can have a little bit broader understanding of where we're coming from, why we do what we do, and also why we don't do some things that maybe you think we should do. So, as Jane said, I'm Ted Krickan. I work here at the Cowrie Clinic in Sechelt and at the Sechelt Hospital. I have no conflicts of interest. I don't work for BC Cancer. And the first thing that we're going to talk about in terms of your Screening 101 class is why do we screen? And an important point here to make is that screening is for patients that don't have any symptoms, or they have very, very early symptoms. So if you have symptoms already of something, you're worried about a disease or a cancer, then you should actually be talking to a practitioner about getting that diagnosed and treated. And that brings me to the opposite, which is why don't we screen, and that's for people who have symptoms. So if you have symptoms, this is a really important point. You actually need more urgent diagnosis and treatment than a screening program. And my example of that is, if you've noticed a lump in the breast, you shouldn't be waiting around for your screening mammogram. You should be seeing a doctor or a nurse practitioner, getting that actually checked out. So if you've already got something you're worried about, we're not talking about screening at all. So go see somebody, try and get in where you can, and get that looked at. Screening is for that early stage so that we can get ahead of it, as Jane said, and prevent it from becoming a problem. So my next slide is going to be a very busy academic slide, and this is Screening 101. It's a university course, so take some notes. But I'm going to go through a very busy slide and try and distill it down in a way that's easy to understand. So Wilson and Youngner are epidemiologists who came out with a set of principles on how we should design and implement screening programs. So I'm going to go through, there's 10 principles, we're going to talk about them. The first one is that whatever condition we're screening for should be an important health condition. It should be something that actually we should spend the money screening for. The second one is that we should actually understand enough about it that we can find a test for it, find a treatment for it, and we know how it progresses. And thus that there is an early stage or a latent stage in the disease where we can pick it up, make a difference, diagnose it, treat it, so that it doesn't become a problem. And there should actually be a test for that early stage. So if we know all about it and we know there's a latent stage, but there's no way to test for it, then there's no point in screening for it. And that test should actually be acceptable to the population. So my favorite example of this is that we have all kinds of internal organs. They all have the potential to develop cancer. The best way to tell that would be to bring you to the operating room, open you up, and look at all of your organs. But doing that every 2 years isn't actually going to be acceptable to most people. And there should be an agreed-on policy on who we treat if we do identify disease, and then we should actually have a treatment for it. So if we go to all the trouble of looking for and finding diseases and developing tests, but we don't actually have a treatment for it, again, no point in screening for it because there's nothing we can do. And then following on that, we actually need the facilities to diagnose and treat it. So again, we can spend all that money finding it and knowing that there is a treatment down at the Mayo Clinic, but if we don't have access to doing that diagnosis or that treatment, there's no point in having a screening program here. And then this is the key one here is that the cost benefit of doing a screening program, and this includes the cost of the screening program, then the diagnosis, then the treatment, has to be feasible and palatable to whoever's paying. And here in BC, that's the voting public, there's an election coming up, has to think that that disease or that cancer is worth paying the money to screen for, diagnose, and treat, and we actually have to have enough money in the healthcare budget to do it. And the last point is that it has to be a continuing process. So we can't just do it September 26, 2024, we did mammograms for everybody. great, you're cancer-free, go home, we don't need to see you anymore. No, because it's an ongoing process. You can still develop it. You have to keep doing screening. So these are the principles that we live by when we're trying to develop screening programs, and public health specialists and epidemiologists try and develop how we actually start screening for something. Now, the big screening programs that we're going to talk about a lot today, they actually tick all of these boxes. They actually are important. We know how they work. We have a test. We have a treatment. We have agreed as a general population that we want to pay for this and do it. But not all cancers fulfill all those criteria. And that's why we have the big four, as I like to call it, that we're going to talk about today, that we have big established screening programs for, but there are actually hundreds of cancers out there. And they don't all have a screening program because, yes, they're mostly important diseases. We know a lot about them. We would plan to screen them continually, but they may not have an early or a latent phase that we can recognize. They may not have a suitable test, or if they do, that test is not acceptable to the population, or a lot of cancers we don't actually have a good treatment for. And then again, referencing our political budgets and things, the facilities may not be there, MRI scanners, PET scanners, et cetera, bug your MLAs. And the cost may not have been deemed worth it. So that's why we don't actually screen for all cancers. That's why we only have 4 big ones that meet all of those criteria. So the next thing I want to impart upon you with this conversation is the concept of risk. And this is where the genes come into things a little bit more. The first one is average risk. So this is the average person where we can't actually identify anything about your medical history or your exam that puts you at any higher risk than anyone else of whatever the disease is that we're screening. And the opposite of that is increased risk. So there is something that we can screen for, or that we can see in your history or talk to you about that makes you at higher probability of developing a cancer. And the degree of risk is actually what can change how your screening works. So hereditary cancers in the family, whether you're a smoker, lots of different risk factors like that, they can actually change your risk and change your screening. And the couple of examples are, if you have a first-degree relative with colon cancer, you should actually bypass the FIT screening at the lab, and you should be going for a screening colonoscopy. And that's a different way of screening. It's still screening, but it's a different way. It's a little more intensive. Or, as Jane mentioned, the hereditary cancer screening program. So if you have a really strong family history of cancer in general, or if you have first-degree relatives with cancer, for any of these big 4, that's probably going to change your risk profile, and you should be talking to a practitioner about whether that means you should be seen by the hereditary cancer clinic, or whether or not, despite that family history, you may still fall into the regular risk category. And that's where things get a little bit tricky, and there's a lot of back and forth about that. But the big message from this is that if you're increased risk, you need to talk a little bit more about that with someone who knows what to look for, what exact family history is relevant, because a lot of patients come in and say, oh, I got lots of cancer in my family. But automatically I'm thinking, okay, is that in a father, mother, aunt, uncle, son, daughter, sibling? Those are the questions that I want to know, because if it was just in your grandfather on one side and a grandmother on the other side, that's not actually all that strong with a genetic link. But if your grandmother had it and your mother had it and her sister has it and your sister has it, that's really strong link that we need to know about. So if you have a strong family history, you should be talking to a practitioner about what that means. These big 4 screening programs, however, and the DIY nature of them, the big target for this is the average risk person. So a person where we haven't really picked out anything that makes you at higher risk than anyone else. So what do we screen for? What are the big 4? You've heard about them already: colon cancer, breast cancer, lung cancer, cervical cancer. These cancers all tick all those boxes on that big, scary list that I had up earlier. And I just wanted to mention a couple of other cancers that we do screen for in our practices as practitioners, doctors, nurse practitioners, but they don't actually tick all those big boxes or all those 10 boxes on the screening list. So skin cancer is one of those. We do screen for it. We do encourage you to get screened for it. But because there's a lot of variation in what's out there for skin cancer, that's something that needs to be done by a provider for you. It's not something that BC Cancer has rolled out a program for. And prostate cancer is another one. Prostate cancer screening is a huge talk all on its own because there's controversial evidence, there's differing opinions with different medical bodies. We still do screen for it actively, but again, because it doesn't tick all those boxes, there isn't a big established prostate cancer screening program. So we're going to move on. We're going to talk in detail about the big 4 cancers, and so I'm going to ask Melissa to come up and join us.